Hello, everyone. My name is Bryant Nguyen. I am a professor of medicine and also the division head of pulmonary and critical care here at Loma Linda University. First, I want to say thank you to the organizing committee for having me here at CTS. My lecture today is on resolving the controversies with SEP1 and the management of septic shock. I have no financial disclosure. Now, as we all know, sepsis is a pretty significant field of study, and there are several controversies at the present day. First, there's the diagnostic criteria. Should we be using sepsis 1, sepsis 2, or sepsis 3? There's the use of procalcitonin to identify sepsis. Fluid bolus. What type of fluid should we use and how much? And then there's the fluid versus early vasopressor. That's a significant topic of discussion today. Timing of antibiotics. I think we all agree that early antibiotic is significant, but do we need it to give it within the first hour of sepsis versus later? Steroids. Several decades of research. It seems like steroids come and go depending on what new studies are coming out. Vitamin C. I definitely hope nobody's giving vitamin C anymore, but that's still a point of discussion. And however, I think the most significant area of debate is the current sepsis core measure, SEP1. So for my presentation, I would like to focus on sepsis 1 as a controversy. And as far as what you have read in the literature about sepsis 1, I'm sure you heard that sepsis 1 was based on the Surviving Sepsis Campaign, Sepsis Bundle, and guidelines. However, the SAC bundle was based on the original early goal directed therapy study, which was a single center study. SSC and EGDT were both driven by industry at the time. And then it was not proven in later big multi-center studies. And with respect to the SEP1 measure, it's not based on high quality evidence, such as the timing of antibiotic and also the fluid bolus of 30 cc per kg. All these is most likely what you've heard about. And as far as in the literature, there's multiple editorial. Here is one looking at SEP1 as a measure that need resuscitation. Antibiotics and fluid focused bundles potentially can improve sepsis management, but high quality evidence is lacking. The CMS mandate for the right disease, but yet the wrong measure is another editorial. Adherence to fluid resuscitation need to be reassessed as this one-size-fits-all approach because we're driving blindly, instituting SEP1 without high-quality outcomes data. And here's another one. Treating sepsis is very complicated, but yet the regulation seems to be too simplistic. So there's truly no love for the bundle sepsis care at all currently in the literature. Now, what I would surmise is, according to Teddy Roosevelt, if we're just complaining about a problem without proposing a solution, then it's truly whining. So we all have been just whining about SEP1 versus truly taking care of the patient. So I don't want to spend the rest of the lecture sharing with you comparing the different literature for the pro side and the con side, but rather I like to share with you my personal journey with respect to sepsis in the last 20 years or so. Since I was the original co-author of early goal-directed therapy with Manny Rivers, we also look at early lactic clearance, showing that 10% clearance within the first 6 hours is significant. At Loma Linda, we're probably one of the first institutions that were able to combine both early goal-directed therapy, corticosteroids, and also recombinant human activated protein C within the first 4 to 6 hours, almost 20 years now. We were also one of the first centers to implement the bundle for early management of severe sepsis and septic shock, showing decreased mortality. We developed an educational course using simulation, and this again is a number of years ago, showing that we can actually train medical students to perform early goal-directed therapy and the sepsis bundle. I also was involved in looking at different prognostic score, comparing in those patients who met the criteria for the bundle. We then took the Surviving Sepsis Campaign bundle to Asia and implemented that as a quality improvement project, showing a significant outcome similar to the data in US. Then we propose that lactic clearance should be added to the bundle. The bundle today that include lactic clearance is based on some of these data. And more recently, a group of us reviewed the literature comparing the original data of oligo-directed therapy to the 3 trials that you're familiar about, Process, Promise, and Arise. And we tease out the differences and to show that they are truly different patient populations. But more importantly, I've been there at the bedside for the last 20 years, taking care of these patients. I pride myself on being very hands-on, doing CPR here in a patient as well. So how did it all start? Well, it's over 20 years ago when Dr. Manny Rivers noted that ED waiting times are significantly increasing, and this is data in the 90s. I think this is not news to us today, but back then, more than 3 hours or 6 hours is pretty significant. And importantly, for the world of sepsis, he also saw that patient can come in initially with SIRS with a mortality less than 10%, but yet transition to full-blown septic shock within the first few hours of ED presentation, resulting in a 46 to 50% mortality. And this is the time of intervention that we need to understand. And some of his earlier work on SVO2 was truly not in sepsis, but rather in cardiac arrest. This is an observational data where he noted that in patient in cardiac arrest, that the SVO2 was averaging 30%, sometimes less than 30% in those patients who did not have ROSC. And in those patients who did have ROSC, they had significantly higher central venous saturation. And then he took it to a preliminary observational study. And this is really the foundation for the current the early go-directed therapy randomized trial. He initially saw that in those patients who came in to the ED, had a pretty much hypotension, low blood pressure, and high shock index. With some resuscitation, the blood pressure normalizes, decreased shock index. However, up to 86% of those patients still had low SVO2 and high lactate, requiring further resuscitation in order to decrease lactate and improve SVO2. And in those patients, 86% of them actually end up requiring mechanical ventilation. 2 of them required transfusion. 9 patients needed more IV fluids, even though the blood pressure was already normal. And 12 patients end up requiring vasoactive agents. So this data was really the preliminary result to start the study. And this was in the late 1990s. So where was I in the late 1990s in 1997? I was actually a medical student here in California at UC Irvine. I was completing my medical school, and then I took a rotation at Henry Ford Hospital in Detroit and Matt Manny, and I matched there in a combined training program in both internal medicine and emergency medicine in 1998. And that was basically the early part of the study where Manny was enrolling patients, and I want to share with you a typical patient that was enrolled in the study. So this is an 84-year-old female with septic shock due to pneumonia, non-STEMI, acute liver failure, acute renal failure, presented with a blood pressure of 65/34, a heart rate of 132, a respiratory rate of 28, lactate of 9.3, hemoglobin 6.7, creatinine 3.2. Treatment received during the first 6 hours included a central line to monitor CVP and SVO2 within 1 hour, and the CVP was 2, SVO2 was 35%. Patient received 6 liters of normal saline, 50 grams of albumin, 4 units of transfusions of blood, antibiotics, intubation, mechanical ventilation, started both on norepinephrine and dobutamine with a repeat lactate of 4.6 from 9.3 during the first 6 hours, and SVO2 normalized. And this was all in the ED prior to ICU admission. Outcome at 7 days, I actually remember this vividly. I went up to visit the patient, and she was actually on the floor, on the regular floor, sitting in a chair, waiting for discharge to a skilled nursing facility. And this was a typical patient that we saw at the time being enrolled in the study in the treatment arm. 3 years later, it was published in 2001 as far as the early goal-directed therapy in the treatment of severe sepsis and septic shock. In addition to decreased mortality, We also saw that there was decrease in vasopressor use, decrease in PA catheter use, decrease in mechanical ventilation, decreased hospital length of stay. So importantly is that we surmise that the protocol did not increase the chance of pulmonary edema. As a matter of fact, there was decrease in mechanical ventilation and possibly decreased the chance of ARDS developing with significant decreased length of stay. So these patients were not overly resuscitated, was not overloaded. In addition, we saw that in those patients who had a significant lactic clearance, and a cutoff seems to be 10%. So if we can clear and decrease the lactate by 10% within the first 6 hours, there was a significant improvement in survival up to 60 days. So that was the study that I contributed to during my residency. Then when I came here in Loma Linda in 2003, this is the scenario at the time, and this is 2 patients. To the left is your trauma patient, comes in with a broken leg from a car accident, end up getting sometimes up to 10 people around the bed hovering over the patient, and a lot of time the patient actually either go home or get admitted to the floor. Did not require surgery, but yet we spend significant resources. To the right here is patient who's in obvious septic shock, hypotensive, and I barely can get anybody to help me because the trauma patient was more important. Now, fortunately, at the same time, the Surviving Sepsis campaign came into existence with the first guidelines published in 2004. And along with that, there was a creation of a sepsis bundle. There were 2 of them actually, a 6-hour bundle and then a 24-hour. So some of us may remember at that time, we had to do a 24-hour bundle in the ICU in addition to the 6-hour bundle in the ED. So at Loma Linda, we also implemented our version of a bundle. They included CVP and SVO2 within 2 hours, antibiotics, early goal-directed therapy, appropriate steroids, and we also already had lactate clearance as part of our Loma Linda bundle. And when we were able to complete the entire bundle, there was a significant decrease in mortality of 21% compared to 40% in those who did not have the bundle completed. Then we took this protocol or sepsis guidelines throughout the hospital over a 5-year period, up to 1,200 patients, and we saw a decrease in mortality from 30% initially down to 20 to 22% mortality over 5 years. Then in 2012, Dr. Rivers at Henry Ford Hospital proposed a sepsis core measures for CMS that started with the National Quality Forum, and this was the initial template for the sepsis measure that we see today. Unfortunately, at the same time, process study came out, as you remember, and just to review, it was enrolling 31 U.S. hospital, randomizing 1,300 patients in 3 arms. One was early goal-directed therapy. Second arm was a protocol-based and non-invasive using blood pressure and shock index as an endpoint. And the third arm was really just usual care. And we know that the study showed no difference in outcome as far as mortality. And 2 other studies follow. One was in Australia with the ARISE study. The second one in the UK with the PROMISE study. Both of them also show no difference in mortality. And when they combine these 3 studies in a patient-level systematic meta-analysis, we saw that there was also obviously no difference in outcome. However, the authors did comment that the analysis is also limited by the underlying internal and external validity of the 3 trials. None were blinded, which may introduce bias. The control groups themselves may not be representative of the usual care in all settings. So even though this was research, the authors already admitted that it may be not true with respect to what we actually saw in the usual care settings. But importantly is I think we can learn from these experience. It appears there may be 2 phenotypes with respect to septic shock if we look at the SVO2 and lactate in combination. The original study, lactate, and when we look at SVO2 and lactate, the early goal-directed therapy had very high lactate, 7 to 8, and SVO2 of less than 45, 50%. Whereas the other 3 trial, very normal SVO2 actually, even though a high lactate in the 4s, So it begs the question of two different phenotypes, and rightly so. The early gold rocket therapy had a significant higher mortality than the other three studies with a mortality 15% to 25%. So truly a different phenotype with respect to shock. So after process, I would say this is what we see today as far as the usual care. This is a 56-year-old male with CHF, end-stage renal disease, presenting in septic shock due to UTI, E. coli, bacteremia. Comes in with a blood pressure of 79/42, heart rate 132, lactate of 5.3. In the ED, because of usual care, based on process, antibiotic was given, ultrasound was measured, resulting in 1 liter of fluid based on an IVC measurement. Repeat lactate 4.5, so a decrease in lactate. Central line was placed for norepinephrine and vasopressin, and truly no more fluid resuscitation or hemodynamic monitoring. Patient actually stayed in the ED for 10 hours, not just 6. In the ICU, blood pressure is slightly improved, but the CVP of 4, stroke volume variation of 25%, a venous blood gas shows an SVO2 of 45%. Importantly is the lactate actually increased. And I would say that we see this pretty commonly now, unfortunately. Patient gets some resuscitation ED, then we play catch up in the ICU later. Patient ended up getting intubated. 6 more liters of fluid were given within 4 hours, epinephrine, phenylephrine added. And unfortunately now the patient is severely ill, and discussion of comfort measures and withdrawal of life support occurred, unfortunately. So even though with that, in 2015, CMS approved the measure called SEP1, as we know it today, the Early Management Bundle, Severe Sepsis and Septic Shock. And this is basically the measure that you've seen. Every hospital in the United States is accountable to this. Within the 3 hours, measure lactate, obtain blood cultures prior to antibiotics, give the antibiotics, and administer a 30 cc per kg crystal fluid for hypotension or lactate grade 4. Now, within 6 hours, we have to apply vasopressor if the patient is still hypotensive. In the event of hypotension after initial fluid administration or lactate grade 4, then we need to reassess the volume status, and we can talk about what that means. But lastly is to remeasure the lactate to make sure that it cleared appropriately. So what does reassessment of volume status means? And because of the result of process showing that usual care is acceptable, I believe the current measure is weak, to say the least, and it's a compromise. It's truly a compromise. So here is the options. Number one, either we repeat a focus exam by a licensed practitioner, including vital signs, cardiopulmonary, capillary refill, pulse, and skin findings. Now, I would challenge anyone here to believe that repeat focus exam actually improve outcome, but that's an option. Or two of the following: measure CVP, measure SVO2 as defined by the protocol early goal-directed therapy, or maybe perhaps the other two options is bedside ultrasound and using dynamic assessment of fluid responsiveness by a passive leg raise or fluid challenge. And it's truly a compromise between this or that. Now, the path of least resistance, I would say, is most clinicians will opt for repeat focus exam because it's easy. So therefore, we can probably meet the measure pretty straightforward by just repeating a focus exam and do nothing else. However, with that, even though it's not perfect, SEP1 does appear to have a signal in decreasing mortality at the national level. And this is preliminary data or preliminary unpublished data, examining close to 2 years worth of data in 3,200 hospitals. That includes yours and mine. Over 1.3 million cases were submitted to CMS. The case that were eligible for analysis was 333,000. And overall, there was a mortality of 30% versus 22% in those patients that were able to complete the SEP measure. In severe sepsis, there was a 7% decrease in mortality, similarly in septic shock as well. So overall, there was a relative risk reduction of 8.6% based on the measure. And importantly is that I know we spend quite some time teasing out what works, a lot of questions on what element works. And from a quality improvement perspective, I don't think it really matters. And this is a comment from Carl Thomas a number of years ago with respect to the sepsis bundles. He noted that a single arrow is easily broken, but not 10 in a bundle. And I thought there's a nice commentary just to remember. So if we don't use SEP1, and I know that's a controversy, then what is truly the alternative? Do we continue to focus on trauma and just do usual care in septic shock? In this particular scenario, just leave the patient alone, give a fluid bolus, and walk away. Unfortunately, I feel that doing that is reverting to what we did 20 years ago. And more importantly, being in academia, how do I teach a resident what usual care is? How do you define that? So unfortunately, the present day of septic shock management boils down to this. Patient comes into the ED, gets some antibiotics, vancomycin, piptazole, get a fluid bolus, and there's debate, is it 250 cc's, is it 500, a liter, 2 liters, and then add vasopressor. And our hemodynamic assessment boils down to an ultrasound to measure an IVC one time. Patient comes to the ICU, more antibiotics are added or de-escalated, source control hopefully with appropriate CT imaging and surgical consult if needed. But resuscitation boils down to, is the patient fluid responsive? And I think that's basically septic shock management today. And more ultrasound is used, measuring the IVC, is the patient fluid responsive or not? If not, keep adding vasopressors, and that's all we do. So it seems like the basic fundamental idea of shock resuscitation, where shock is the inadequate oxygen delivery to meet oxygen demand, resulting in tissue hypoperfusion, has been lost. Because the resuscitation should include improving or optimizing oxygen delivery. Now, we're not talking about supernormal oxygen delivery here. We're just talking about correcting the inadequate oxygen delivery by understanding and optimizing cardiac output, which is stroke volume, comprising of optimizing preload, afterload, contractility, then optimizing oxygen content with hemoglobin if needed, and mechanical ventilation perhaps. So this is the fundamental pathway to improving oxygen delivery, but yet I don't think any of us are doing that today, except for perhaps a few, hopefully. And even though the early goal-directed therapy study was done in a single center, and it may or may not work in certain populations, but the physiology behind these parameters is really based on oxygen delivery and improving oxygen delivery. CVP, a measure of preload, mean arterial pressure, afterload, and SpO2 as a surrogate for contractility after we have addressed the oxygenation issue and also the hemoglobin. And if after optimizing the hemoglobin and oxygen saturation, if SpO2 is low, we consider increasing contractility with inotropic agents. Preload, afterload, contractility, oxygen content. And we repeat it, so we circulate to the protocol. So for today, if we don't like CVP, we use our SVV, we use preload measures, afterload, and also definitely consider SpO2 or SvO2 as a surrogate for contractility. Because if just targeting cardiac output alone, that's not adequate because everybody does not need to have a cardiac output from 4 to 8. Some can tolerate a cardiac output of 2 to 4. Some may need a cardiac output of 8 to 10. It's truly SvO2 that will tell us if the patient needs a higher cardiac output. So because of such focus on just the fluid responsiveness and the fluid bolus and missing the entire concept of optimizing oxygen delivery, I've been giving a similar lecture in the last 10 years on how to appropriately resuscitate patients using adequate hemodynamic monitoring. And just recently, one of the residents decided to take this on and put that lecture into print. And I collaborate with Manny Rivers, and we just publish this. And I definitely hope this would be a resource for training purposes. And basically, in the paper, we address everything. How do you measure preload? What are the different measures of fluid responsiveness? Passive leg raise is not the only measure. We need to remember the Frank Starling law and the venous return curve. CBP, even though the absolute measure is not adequate, Max Harry Weil in the 60s defined the 520 rule of fluid responsiveness using CBP. IVC collapsibility, I'm sure we are very familiar with passive leg raise using SVV or post-pressure variation. So that's fluid responsiveness. Now, all this is based on measuring stroke volume. So what are the technologies out there? So we review the various techniques, the indicator dilution, which is your thermal dilution being the reference standard, post-contour analysis, echocardiography, bioimpedance, bioreactance, and also ultrasound Doppler. Optimizing afterload, then improving contractility, increasing oxygen content. How do we address these parameters beyond from just fluid responsiveness? How do we target contractility and hemoglobin guided by SVO2? And using both SVO2 and lactate as a resuscitation endpoint in order to optimize the oxygen delivery versus consumption curve. We talk about fluids versus vasopressors, early versus late, and then putting it all together in a nice protocol targeting preload, afterload, contractility, oxygen carrying capacity, and oxygen content. And we've end up the article with a case example. So to me, this is how we should be approaching shock, especially in the ICU when we have trainees beyond from just doing a passive leg raise or fluid responsiveness with an ultrasound. That is only just scratching the surface with respect to resuscitation. So I would really encourage everyone to remember that we need to optimize oxygen delivery in order to resolve shock and not just debate only about the fluid bolus and the timing of antibiotic. So with that, thank you so much for your time, and I definitely can entertain some questions. Thank you.